call the first presenter.
Good evening to all. We invite you all for this poster podium presentation for AIOS2025. So, I request the first speaker, Shivi Jain, to speak on conquering rickettsial retinitis, doxycycline impact in 5 case reports.
Dr. Shivi, please. Is the first speaker there, Dr. Shivi Jain?
Okay.
Do we have Dr. Arush? Dr. Bharat? So we have Dr. Bharat with us, who will be presenting retinal manifestations in demyelinating diseases of CNS.
You can start.
The timer is still tells.
Yeah, if you start, the timer will start going. You start.
Good evening, everyone. I'll be presenting on retinal manifestations in demyelinating diseases of central nervous system. This is a study we conducted at RP Center in AIMS, New Delhi, along with the Cardio Neuro Center in AIMS, New Delhi. The basic introduction, everyone knows here that demyelinating diseases involves involvement of brain, spinal cord, and sometimes eye as well. There are various multiple diseases known as multiple sclerosis, neuromyelitis optica spectrum disorders, MOGAD, and other non-MS inflammatory disorders. Visual symptoms are commonly found. Optic neuritis is the most commonly described presentation, but retinal findings are very less described, or they are infrequently described, and major of them are described in a retrospective manner. In a cohort of MS patient, cohort of uveitis patients. The uveitis patient was evaluated and seen how many of them had MS. It was not done in the other way around. So our focus was to study the MS proven cases, MS, MOGAD, and MSD and other diseases, and to find retinal and uveal manifestation in those patients. So study design, we did a descriptive observational study in which we recruited 50 patients with proven diseases from neurology department. Then inclusion criteria was consent, confirmed diagnosis, age more than 8 years, and exclusion criteria was demyelinating diseases from infectious etiologies. Patient evaluation was done, treatment history, and systemic examination, following which we did an ocular examination in which we best corrected visual acuity, IOP measurement, pupillary reaction, contrast sensitivity, slit lamp examination, fundus evaluation, swept source OCT angiography, ultra-wide field fundus photography, and ultra-wide field fluorescein angiography if required, if we found some lesions that may require angiography. So the results were as follows. Majority of our population was female, 32 females out of the 50, and mean age was 18 to 30 was the mean age. Majority was multiple sclerosis, and they were mainly on the treatment. Some had steroids, some had azathioprine, DMF. So the vision loss, when we saw the patients, we did not evaluate the patient under the attack. We evaluated patients who has a history of MS, and currently they are not having any ophthalmic symptoms. So some patients had good vision, like 67% has normal vision, then 19% mild vision loss, and moderate in 4%, and severe in 2%, and legally blind were 8% cases. This is according to ICD-11 classification. The findings we found was pars planitis, microhemorrhages. Obviously, optic disc pallor was the most common finding, as you will all expect. But the other findings were a bit revealing, like vascular sheathing, microhemorrhages, which were not previously described, vessel attenuation, and there's a non-specific depigmentation we found in around 10% patients, which was not described anywhere. So this was the laterality of the findings we found. So some findings I'm showing you. This is a RP hyperplasia. You can see I have marked it. Then there were vasculitis-like features, neovascularization with hemorrhages and vascular tortuosity. and there was resolving vitreous hemorrhage inferiorly. Then a non-specific depigmentation. This we found in around 10 of our patients, which was not previously documented, but a bit more research is required to study them. Disc pallor was the most common finding, as I told already. Then vessel deposits. You can see this is not an artifact. We have confirmed this because sometimes in optos imaging the artifact can be mimicked like that, but these are vessel deposits we see in multiple patients. These are the two photos I've given. Then vitreous deposits like focal astrohyalosis like changes we can see in the vitreous. Then microaneurysms were found in some patients in the periphery. Then there was a peripheral retinal atrophy along with RPE hyperplasia was seen. And the results were, overall the prevalence was 60% among the patients of clinically proven MS and other demyelinating disorders. Most common age was 31 to 45 years. Majority was a female gender. Retinal vascular changes were 28%. Acute uveitis was only seen in 2% patients, the vasculitis one. None of the patients had CME. So conclusion is 60% associated in our small group of patients. So our recommend is pursue screening of all patients of demyelinating diseases to, for the retinal and uveal manifestation as well, as we all screen them for the disc only. We have to examine their periphery and screen for cells and flare as well. Then try to understand the association between primary demyelinating CNS disorders along with the uveal and neuronal manifestations. And if possible, to response resistant to therapy can also be prognosed according to this. Thank you.
Thank you, doctor. 8 patients had blindness. Blindness due to what?
Ma'am, repeated attacks of optic neuritis. Like out of 8, as far as I can remember, there was 3 patients of CRION. So they had repeat attack of optic neuritis, severe disc pallor. And some patients had INS, and they also developed all those things. Mostly because of disc pallor, not retinal or uveal manifestations.
So in the light evaluation, how many patients had RAPD?
RAPD, if the attack was active, I took 50 patients who were clinically proven. Some had active optic neuritis, some didn't have. So as far as I can remember, around 30 patients had RAPD out of the 50. So disc pallor was the most significant finding, as I told earlier.
Were these patients ever examined before?
Some of them were these first-time diagnosed, so I examined them first. Some of them were diagnosed only for the disc findings and color blindness and everything, nothing else, not for the retinal or uveal
was
manifestation.
never examined.
No,
Did they have any other comorbidities which could account for these manifestations? Did you exclude
Comorbidities
them?
maybe due to treatment like that. One patient that had microaneurysms, word has pulmonary hypertension. She had that. Some majority were system treatment associated comorbidities, like they were on immunosuppression and multiple steroids because of that, but not previous comorbidities. As all the patients were younger age group, no? I told you 31 to 45 years was the majority population.
Just an observation, ma'am. You can correct me if I'm wrong.
Yeah.
You can actually split it into 3. There is actually only one. One is optic atrophy, which is the most common thing found because all patients are of multiple sclerosis, no doubt. On the other end of the spectrum, you have, I think you have 1 or 2 patients of pars planitis.
Yeah.
That is the only actual uveitic entity which you'd actually described in all your these things. All the other findings which you described, given your median age of patients, you will find areas of peripheral chorioretinal atrophy, you will find a vein occlusion with the vitreous hemorrhage, atrophic retinal patches. These are very, very common findings which are picked up in a normal eye examination in anybody above 50-60.
But the vein occlusion, as you was telling, it was a very segmental vein occlusion, not a BRV or something like that you can expect in these age groups or something like that.
Just if you have time, I'll go back to the picture. It's okay, no problem.
Can you please project it?
Yeah, see. So that is
That is
typically where the vein occlusion happens, no? Infratemporal vein.
Inferotemporal, but it's not classic BRV that we see in these. And these were young patients.
How
and no
old
other
was this
systemic
patient?
comorbidities.
How old was this patient?
I don't know exactly, can't remember exactly the age, but she was young.
I was looking at the other vascular changes and all. Okay, this is easily a
our view.
Wrong side of 40 and at least a hypertensive. You look at the AV changes and all those stuff.
Unrelated to the demyelinating disorder.
Yeah.
The question is, how do you attribute these
Yeah, that's, see,
changes
why I place those 3 points
to
is
demyelinating disorder?
exactly. That is what is running through our
It could
minds.
be that what we want to ask is that these could be incidental findings as
I
well.
agree to that. Yeah, for that to exist, to associate them with the demyelinating disorders, we had to do a follow-up study as well. We did only once a view study, so that time the finding could coexist.
Yes, so this is just a cross-sectional
Yeah.
observation study.
Thank you, Dr. Bharat.
Thank you.
Thank you.
Thank you.
So next, do we have Dr. Namita? Dr. Namita will be presenting clinical profile, imaging and treatment outcomes of retinal vasculitis in a tertiary hospital in India.
Good evening, everyone. I'll be presenting the clinical profile, imaging, and the treatment outcomes of retinal vasculitis at a tertiary hospital in India. The aim of this study is to describe the clinical profile, FFA, SSOCTA findings, and the treatment response among patients with retinal vasculitis. It was a retrospective observational case study from 2016 to 24. All patients had optos imaging, FFA, and SSOCTA done with tailored lab investigations, following which the treatment was initiated. Coming to the results of our study, a total of 136 patients were analyzed, in which the majority of patients were found to be in the age group of 31 to 40 years. 81.6% of our patients were male. The most common presenting complaint was diminution of vision, which was accounted for among the 64.7% of patients, followed by floaters in 14.7%, and the disease was bilateral in 53.6% of patients. The most prevalent presenting complication was vitreous hemorrhage, which was noted in 19% of the patients, followed by retinal vein occlusion in 8.1%. The most striking fundus fluorescein angiogram finding was peripheral vascular leaks seen in 23.5% of the patients, followed by neovascularization elsewhere with capillary non-perfusion in 21.3%. Capillary ferning was seen in 15 patients, which accounted for 11%, and most of these patients were found to have Behçet's disease. The most prevalent SSOCTA finding in our study was epiretinal membrane, which was seen in up to 68.3% of the patients, followed by ellipsoid zone defects in 39.7%, RP bumps, which was seen in 22%, cystoid macular edema in 11%, and neovascularization in 4%. The most prevalent etiology was TB retinal vasculitis, which was seen in 71.3% of our patients, followed by Behçet's retinal vasculitis in 13%. The other causes were SLE retinal vasculitis and sarcoid vasculitis. Now, coming to the treatment, systemic steroids form the mainstay of treatment in our patients. Immunosuppressive agents were used in 50 patients, out of which mycophenolate mofetil was the most prevalent agent, and biologics were used in 10 patients, in which adalimumab was the most prevalent agent. Seen on the right is a patient with TB retinal vasculitis, which improved remarkably after treatment with ATT and steroids. Retinal lasers and surgery were also done where indicated. Seen at the bottom is a patient with Behçet's uveitis, which showed a remarkable improvement after treatment with adalimumab. The ultimate visual outcome post-treatment showed an improvement in 31.6% of the patients, and the vision was maintained in 52% but worsened in 12.5%. Comparing this study with a similar study at a tertiary eye care center in eastern India, the demographic data was similar. However, the macular abnormalities noted in that study was far fewer compared to ours, and immunomodulatory treatment was only used in 7 7 patients in that study, in which azathioprine was most commonly used and MMF was not. Immunosuppressives in our study were used in 36.7% of the cases, out of which MMF was most common. Lin et al. Have concluded that aggressive IMT is preferred to achieve a steroid-free durable remission for non-infectious occlusive retinal vasculitis. Optic nerve atrophy, macular ischemia, and a poor BCVA at the initial visit predict a poor visual outcome. Biologics were used in 7.3% of our cases, where adalimumab was most common drug. Retinal surgery was indicated in those with persistent vitreous hemorrhage and retinal detachment. Nagraj et al. Have shown that the overall anatomic success rate of retina reattachment surgery in patients with retinal vasculitis is quite good with timely intervention. To conclude, retinal vasculitis may be the initial manifestation of several systemic diseases and is often a diagnostic challenge. It is essential to suspect these etiologies and perform specific investigations that helps to diagnose them early and prevent dangerous complications. Thank you.
Thank you. In this 36% of the cases you have used immunosuppressive therapy. In that you have chosen MMF as the first drug. Any specific reason?
No reason, ma'am. Ma'am, all the patients were seen by single physician, single consultant, Dr. J. Biswas. So, sir prefers to use MMF first in most of his cases. So
maybe because
And
big chunk of them were Bessett's also.
in TB, also sir has used my MMF first.
And in the commonest was the TB. In TB, retinal vasculitis, did you see any specific pattern, like scar along the vessels? Those kind of a thing was seen in how many percentage of patients?
No specific pattern, ma'am. It was
especially when we put it like, you have a TB specific pattern, like for example, sarcoid, you'll have a Candleback's
Candleback's, yes.
and SLE, you will have multiple cortical spots with vasculopathy. So the typical ones, what's how many, and the atypical how many, that will help you to characterize them morphologically in addition to the etiological one to correlate with the imaging biomarker.
Okay.
So how did you come to the diagnosis of TB vasculitis?
Ma'am, based on the laboratory investigation, MAN2, QTB, HRCT chest, and the clinical features, if they were eels-like manifestation clinically.
Yeah, I'll just ask if the next speaker is there. Can I just have one speaker?
Thank you, Dr. Namita.
Thank you.
Thank you.
Thank you. If the next speaker doesn't mind, can we have free paper number 1083, Dr. Priyanka? Dr. Priyanka is not here, so Dr. Bhavna Sharma is just going to substitute and read the paper and go for as a judge in another session. So if the next presenter doesn't mind, can I have Dr. Bhavna Sharma? Free paper number 1083.
I thank the esteemed judges for considering my request, and I would be reading this paper on behalf of my colleague, Dr. Priyanka, who is an excellent Uvea person, and today she could not be here because of the leave was not sanctioned. I would be reading here. So she wanted to present on epidemiology, clinical features, and treatment outcome of Fuchs uveitis syndrome in central India. As we all know that Fuchs uveitis syndrome is a chronic form of uveitis caused by mild inflammation and typically unilateral, often asymptomatic during routine examination. The diagnosis is mainly based on clinical features. However, in absence of typical features, it could be misdiagnosed and cause unnecessary corticosteroid exposure to patients. Etiological factors have been varied, and there have been multiple factors being implicated that range from genetic to infectious agents like rubella, cytomegalo, virus, toxoplasmosis, and HSV. The main complication here is the cataract development due to chronic inflammation and sometimes long-term use of steroids also. Although patients with Fuchs have a good prognosis, but incorrect diagnosis may sometimes lead to unnecessary steroids, development of cataract, and secondary glaucoma. And if there's the feature of vitreous involvement due to continuous inflammation, the surgical outcome may also be varied. And So this study was a retrospective single-center case series. We've included all consecutive patients who presented with Fuchs uveitis or who developed during follow-up. The lack of the exclusion criteria was the lack of diagnosis of Fuchs in medical records. The clinical assessment was done with detailed clinical history, examination, relevant lab investigations, and supplemented by OCT FFA wherever required. Outcome measure was improvement in BCVA. We saw that the study includes 19 eyes of 19 patients, and there was a female preponderance. The mean age was around 34 years and mean IOP around 17. The mean follow-up was done for 23 months, and the affected eye was right eye more than the left eye. The clinical characteristics, the most common presenting feature was decreased in blood vision, in addition to floaters, keratotic precipitates, and other clinical signs which were seen were heterochromia, iris nodules, inflammation in the vitreous, and anterior chamber. We saw that the posterior capsular opacification was the commonest complication, and it led to mature cataracts in some cases, glaucoma, and it was managed by SICS, phacoemulsification. However, PCO was seen in around 50% of these cases. In our series, the most common age association was between 18 to 42 years, and as I earlier said, that female preponderance was seen. 20% of the cases were diagnosed as either anterior or intermediate uveitis elsewhere at the time of presentation, and 16% were diagnosed on our examination. The most common symptom was blurred vision. The most common clinical characteristic was presence of diffuse stellate keratotic precipitates. After cataract surgery, PCA was noted almost in 50% of the cases. We would like to conclude by it should be a careful evaluation of such patients who present to us with blurred vision, particularly young patients, because lack of knowledge of posterior segment manifestations or absence of typical signs may lead to misdiagnosis and unnecessary exposure to steroids. Most encountered complications in Fuchs are glaucoma and cataract, hence close follow-up is required. And we require new development and new research in IOL designs for effective management of such cases. Thank you very much for giving me a patient hearing.
Thank you. Yes, most often is underdiagnosed and overtreated with steroids. It's important that we recognize this entity.
Yeah.
Thank you.
And since she's a cornea person, I think she will spare her the questions. Thank you, ma'am. So, next speaker.
So next, do we have Dr. Abhidna?
Abhidna Surve? No? Okay.
Dr. Eliza Anthony?
No?
So she's there.
Oh,
So
sorry.
she will be presenting paracentral acute middle maculopathy-like lesions associated with ocular and systemic inflammation.
A very good evening to everyone. I'll be presenting a retrospective case series of paracentral acute middle maculopathy-like lesions and Persner-like retinopathy. These are the ischemic maculopathies and their association with systemic diseases. So we have 6 eyes of 5 patients. First case is an 18-year-old female who presented with left eye blurred vision, acuity of 6/9. Fundus showed Persner-like retinopathy with pallid retina. OCD showed band-like hyperreflective lesion extending from the inner nuclear layer to inner plexiform layer and in some areas even inner layers. There was a wavy outer plexiform layer showing segmental thinning of the INL, and even you can appreciate this prominent middle limiting membrane-like lesion, which is an ischemic lesion. FFA showed hyperfluorescence and ICG showed hypocynescence corresponding to the lesions. On evaluation, peripheral smear, echo and lipid profile was normal. However, partial occlusion was noted in bilateral common external and internal carotid artery on Doppler. So in such a young age, we suspected autoimmune pathology and we did a workup. Priyanka came to be positive, which could be causing the ischemic events because of the premature atherosclerosis. So she responded very well to the oral steroids. Second is a 45-year-old male who presented with bilateral anterior scleritis with blurred vision, acuity of 6/9. Fundus showed again parafoveal whitening. PAM lesion was seen in both eyes on OCT. However, right eye showed coexisting AMN lesion. You can appreciate the ellipsoid zone subfoveal disruption here. Octa showed phlovoid areas in the deep plexus. So considering the inadequate response to systemic steroids which were given elsewhere, history of contact with the pet dog, elevated toxo-IgG titers, we made a provisional diagnosis of toxoplasma-associated anterior-scleritis and PAM. And this time he responded well with oral steroids as we added oral azithromycin monotherapy for 4 weeks. So third was a 22-year-old male with left eye blurred vision, acuity of 6/9. He presented with right eye cotton wool spots. Left eye also had cotton wool spots along with a BRAO and an adjacent white pallid retina. OCT showed PAM lesions again. However, FFA showed hypocynosins and mild perifoveal vasculitis here. ICT showed hypocynosins. So considering bilateral ischemic changes, vasculitis in the right eye, history of recurrent papilla skin rashes, along with the HLA-B51 positivity, we diagnosed him with Behçet's disease, and he showed good response with oral immunosuppressives. Fourth was a 63-year-old female who presented with light perception vision in the right eye, and she presented with personal retinopathy. You can see the pallid disc edema. Fundus showed again PAM lesions. She had significant arthritis, and her ANA was strongly positive. So she was diagnosed with the SLE-associated PAM and PLR, and oral steroids were initiated. However, she showed poor response to treatment. Last case is a 21-year-old male with right eye blurred vision, acuity of 636, again posterior pole pallid retina with PAM lesions on OCT. He also had arthritis, both rheumatoid factor and ANA was strongly positive. So he was again diagnosed with the autoimmune possibly associated PAM and PLR. He was initiated with oral steroid and had good response. So both personal-like retinopathy and PAM have known association with autoimmune diseases like SLE and Behçet's. However, we present a unique association with P-ANCA. Autoimmune disorders, including P-ANCA positivity, can lead to premature atherosclerosis in young age and accelerated plaque rupture. And this can predispose to ocular ischemic events, especially in the watershed areas in the retina, that is the posterior pole, and even the cardiovascular incidence. Again, the last case, the toxoplasma also has been associated with scleritis and retinal vascular occlusion in literature. However, in our case, bilateral scleritis with PAM was present. In the absence of retinitis, it is often labeled as idiopathic, but it may represent an atypical ocular toxoplasmosis, a rare association. So in presence of these subtle ischemic insults of PAM and PLR, they are the biomarkers of underlying disease, which could be life-threatening as well as sight-threatening. So this should be treated, evaluated, and early treatment should be initiated. Thank you. These are my references.
Thank you, Dr. Elisa.
Thank you.
So most of your patients have underlying autoimmune disease association. Did you see the reversal of the OCT biomarker of PAM? If so, how long does it take?
It took, ma'am, except the second last case, the elderly female, she had diabetes also, so IVMP and steroids were given elsewhere. She didn't improve. But all cases improved to 6/6 with improvement of PAM lesion and little thinning of the inner nuclear layer. But the hyperreflectivity didn't go away fully. But there was a mild hyperreflectivity, mainly of the inner plexiform layer, but inal thinning was noted, and it took almost 4 weeks. The first patient, that the young girl, she almost improved in 2 weeks of oral steroid to 6/6 vision. That little bit of scotoma went away with high-dose steroids.
So what the other question is, visual field defects did you notice? And if so, those defects, how long does it take time to disappear?
We had asked the patient 1 week review post-starting because I wanted to keep a close follow-up. And all the patients, except that fourth patient, demonstrated improvement in their vision in 1 week. And they improved well, all the four, but the fourth patient did not improve. And she was a diabetic.
Asking about the visual fields.
Visual fields we didn't do, ma'am, in any of the patients, just the scotoma clinically. We just did multimodal. Fields were not done.
No, fields also another modality in which you can document the scotoma, and we can see, in addition to the OCT, whether the reversal of the scotoma is happening or not.
Yeah, okay. Thank you so much, ma'am.
Thank you.
Thank you.
Dr. Shruti. Yeah. She'll be presenting pattern of uveitis from Tertiary Eye Care Center among serving soldiers in a high altitude area.
Good afternoon, everyone. I'll be presenting on pattern of uveitis. So sorry. I'm audible? Okay. Yes. Thank you, sir. So I'll be presenting this under following headings: introduction, aims and methodology, results and conclusion. So uveitis is characterized not only by the inflammation of uveal tract, but also involves the adjacent structures such as retina, vitreous, and either directly or indirectly, and is prevalent all over the world. It can occur at any age, but predominantly it affects the working age group, and annual incidence of about 14 to 17 per 1 lakh population, with a peak age in 20 to 50 years. The aim of this study was to see, just to look for the pattern of clinical characteristics of uveitis in patients presenting to tertiary eye care institute, that is a zonal hospital in northern India in Srinagar, J&K. And so this was a prospective cross-sectional study of 84 eyes of 62 patients who were diagnosed between the month of July 2022 to July 2024 were analyzed, and diagnosed cases of uveitis and age group of 20 to 40 years. They were all young and healthy, and in exclusion criteria of previous ocular surgery, any ocular trauma, because we do see a lot of traumatic uveitis, so that was excluded, and other ocular diseases were excluded. So the mean age was around 30 plus or minus 3.62, and because it's only the serving soldiers, all my patients were male, and unilateral presentation was seen in 61.8% of patients, and infectious cause were detected in 19.9, and non-infectious in 23.4. So looking into the etiological classification, yes, the idiopathic definitely accounted for 79%, followed by HLA B27 positive and B51 positive in 5%, and tuberculosis in 2% of cases. And anatomical classification, yes, I did. And when I started the data, I thought entry will be more, but in my patient profile, it was posterior uveitis is more common, followed by intermediate and anterior uveitis, and pyelonephritis was seen in 5% of the cases. To conclude, uveitis is a complex intraocular inflammatory disease. I don't know what was the antigenic response, why they presented, and the amount of severity they were presented were, like, especially for anterior uveitis, they came with vision of PL positive. They had to be heli evacuated to be getting treatment at a eye center, because they used to stay in a far off, winter, totally cut off place, and this is how we were managed. And diagnosis of uveitis is often challenging due to varied pathogenesis and presentations within the community, and to look out for active causes is important. Thank you. Any queries?
You had mentioned high altitude area. Where was this?
Sir, in Poonch and ahead. I was posted at 92 Base Hospital, sir, Srinagar.
Okay, Srinagar.
It's a military hospital.
Yes. Really, it's an interesting one on high altitude.
Yes.
We do not know what is the physiological and what is the
Yes, ma'am.
pathological. There is lack of literature support in that.
Yes, ma'am.
And I just wanted to ask, may not be relevant to this.
Ma'am.
If you see an high altitude retinopathy,
Yes, ma'am,
how
we do.
long does it take to disappear?
Ma'am, actually it depends on what is their initial hemoglobin, viscosity, hyperviscosity syndrome they have. If they have it around anywhere above 18, we do advise for venesection, and we do get their serum APO value done. And if it's normal, fine. If not, as such, if they have, a very recent case was a multiple macular, involving the macula, multiple hemorrhages in both the eyes. So they had a vision of almost, he had come with a vision of almost only 1 meter, gross RAPD and gross visual loss. So we do have a referral system where we send the patient at the earliest, he went to a higher center. Yes.
If they have occlusive vasculitis or vasculopathy,
Ma'am.
and if they are posted in the high altitude, it's
Yes,
going
ma'am.
to exacerbate the pathological.
Yes,
Do you
ma'am.
have a system in which to?
Yes, we do. We do have a system where we when we give their opinion, they're all put in a category that it is written that they're unfit for particular altitude and they'll not be posted. They'll be employed in a place which is not a high altitude, and it'll be kept at a lower place. Right.
Thank you.
Did you rule out any other infectious etiology apart
Ma'am,
from
we do run
tuberculosis?
a battery of investigations, everything VDRL, routine investigations. It's every serving soldier. It's not like how we do it in our civil setup, like, we'll only evaluate a bilateral uveitis. No, and every patient of uveitis was evaluated with battery of including X-ray of SI joints. So we've not left anything not to miss out on any diagnosis. So.
But you
Yes.
could not find out.
No, ma'am. Initially, yes. In few cases, he could not, but a few, around 10, turned out to be HLA-B27 positive. But X-ray SI joint, followed by MRI, then followed by HLA-B27. That's how. What we have at our disposal and then followed by what we don't have.
Yeah, that's a great service.
Right. Okay. Thank you.
Thank you.
Okay.
Do we have Dr. Swatika? She will be presenting ocular lesions. Do ocular lesions still occur in HIV positive patients with heart?
Good evening, everyone. I'll be talking on the topic, do ocular lesions still exist in heart era? Introduction, incidence of uveitis in India is 1 in every 140 people. The ocular inflammation poses greatest challenge, causes significant inflammation, visual impairment in HIV positive patients, and immune recovery syndrome after heart initiation poses greatest challenge in COVID pandemic era due to increased layers to follow-up rate. Methodology, it is a retrospective case series analysis of 25 cases. It is a single study, center study by 2 ophthalmologists at Shankaranathalaya, Chennai. And HIV patients were recruited, those who were with specific visual complaints and more than 2 follow-up visits were included. And from this, and those who have less than 2 follow-up visits were excluded from the study. And intraocular fluid analysis was indicated in selective cases with atypical presentation and severe inflammation with a risk of visual loss and prolonged inflammation non-responding to steroid therapy. And the complete ophthalmic examination was performed, and then including measurement of visual acuity, slit lamp examination, and detailed indirect ophthalmoscopy, and inflammation was graded according to the standard system of classification. Coming on to the results, most common age group affected were 40 to 60 years old, and 44% of the people had moderate visual impairment of 6/60 to 6/18 vision, and majority of the people had a CD4 count between 100 to 250, and more than 50% of the people had bilateral presentation at the initial visit. And we found posterior segment involvement is more common opportunistic infection in 76% of the people, with most common lesion being the cytomegalovirus retinitis, followed by acute retinal necrosis, followed by progressive outer retinal necrosis, and toxoplasma and the optic neuropathy and HIV retinopathy. We had it in 1 patient. And the most common visual threatening lesions were affecting the optic nerve lesions like glaucomatous optic neuritis due to post-viral uveitis sequelae, and any macular lesion due to cystoid macular edema due to immune recovery uveitis, and necrotizing retinitis causing retinal detachment. These are the most significant visually threatening lesions which we encountered. And anterior segment lesions visually affecting will be the viral retinitis sequelae like viral keratitis or any severe uveitis with hypopaean in case of varicella zoster virus. And here are a few case discussion which we treated as like immune recovery vitritis. He presented, initially he was treated for cytomegalovirus retinitis. He completed the course of valganciclovir. After stopping 3 months of treatment, patient developed vitritis and he presented. So we did real-time PCR to diagnose, confirm the viral load and then copies of DNA. And then it showed active copies of around 13,000. And the CD4 count was gradually increased from 70 to 140. So we did therapeutic vitrectomy and then started on steroids and continued the valganciclovir for another 3 to 6 months. And this is another case where we treated initially for CMV retinitis. This patient also developed immune recovery syndrome, immune reconstitutive syndrome like feature after stopping 8 months of treatment is supported by the increase in evidence of the CD4 rise. And these are the few cases where we encountered the latent disease manifested as once we started heart therapy, even with CD4 count. This is one case with tuberculous panuveitis, and this is one case with CMV retinitis who developed after 6 months of heart initiation, even with good CD4 count. And this is another patient with HIV with coexistent syphilis, who developed an atypical presentation like this, and we have diagnostic dilemma, and we did AC-TAP. This is a nested PCR picture showing, because in view of serum, IgG was only positive, IgM was negative, so we confirmed the diagnosis by AC-TAP by nested PCR method, and we treated accordingly. And discussion, compared to our previous study by Biswas et al. In 2013, immune recovery uveitis occurred in 24%, slightly increased as compared to 17.4%. Immune recovery uveitis occurred following a mean duration of 3 months to maximum 3 years in this study. In previous study, we had it around 4 months to 2.5 years. And loss to follow-up rate was 38% in our study. Due to the COVID pandemic era, most of the people lost to follow-up, so might be the cause for increased uveitis. And then utility of aqueous aspirate in posterior uveitis in this study showed 67% success rate compared to 72% of our previous study in 2013, and slightly higher than the study by Stantos et al. Conclusion, Regular ophthalmic examination is needed for all HIV patients, even in heart error, to reduce the HIV-associated blindness through early targeted prophylaxis and appropriate referral services. And if needed, like treatment with steroid and long-term secondary prophylaxis for this kind of immune recovery syndrome is needed. And PCR played a vital role in tailoring treatment for these cases, especially in case of posterior uveitis. Thank you.
So in your cohort, you had cases of ARN. What were the clinical features?
Patient presented with the sudden loss of vision, ma'am. So initially he presented with the anterior. Sometimes we had only 2 patients with that. Initially he presented with the anterior uveitis kind of picture and area of peripheral retinal necrosis. Within the 1 week duration, it progressed rapidly and then suddenly involved the other eye also. So in this study, we had 3 patients with no PL in the both eye. So that kind of progression.
PORN is more common than ARN in immunosuppressed individuals. So the way you describe
Yes,
might be falling into the PORN category.
Okay. Thank you.
Do we have Dr. Premika? She'll be presenting uveitis masquerade syndromes in adenocarcinoma of lung.
We are finishing.
You 2 more are there.
1, 2, 3, 4 people.
Changing of presenting author is not allowed. She did it.
Ma'am, maybe they must have requested it beforehand.
Changing of presenting author.
It is not allowed actually, but maybe they requested it before because the presentation was uploaded.
Can I start? A very warm good evening to all the respected ophthalmologists present here. Today I am here to present a case of uveitis masquerade syndrome in adenocarcinoma of lung. As we all know, uveitis masquerade syndrome can occur due to multiple malignant as well as non-malignant causes. We report a rare presentation of bilateral and multifocal choroidal metastasis from a primary adenocarcinoma of the lung with left eye pseudouveitis and neovascular glaucoma. A 43-year-old woman, she presented with painless diminution of vision in her left eye for the past 1 month. There was no history of any systemic illness, and medical history revealed anorexia and loss of weight for the past 6 months, for which no treatment was sought. On examination, right eye, she had a best-corrected visual acuity of 20/20 and an intraocular pressure of 12 millimeters of mercury. Anterior segment examination was within normal limits, and fundus examination showed multiple yellow-colored elevated subretinal lesions. Left eye had a best-corrected visual acuity of 20/100. Intraocular pressure was 26 millimeters of mercury, and anterior segment showed pigmented hypopyon, keratic precipitates, and fine neovascularization of iris. Fundus examination revealed dense vitritis with an inferior retinal detachment. Ultrasonography of the left eye revealed multiple dot echoes in the vitreous with multiple elevations of the choroid with moderate to high internal echo structure suggestive of vitritis and uveal metastasis. Also noted was an inferior retinal detachment. A thorough uveitic workup was done. All the investigations were within normal limits except for HRCT chest, which showed a lesion which is suspicious of malignancy. So all these features, they proposed to an underlying malignancy with a distant metastasis, and the patient was referred to a surgical oncology team, and systemic workup was done. 18 FDG PET revealed an FDG avid lesion in the right lung upper lobe, metabolically active mediastinal, cervical, abdominopelvic, and bilateral inguinal lymph nodes, and multiple enhancing lesions were noted in bilateral cerebral hemispheres as well as in the liver. Left lung biopsy was done, and histopathology revealed tumor cells having pleomorphic, hyperchromatic, round to oval nuclei arranged in poorly formed glandular pattern with surrounding lymphoplasmacytic infiltration suggestive of a non-small cell carcinoma, and these tumor cells were positive for thyroid transcription factor 1 and negative for P450 suggestive of adenocarcinoma, and the patient was diagnosed as bilateral and multifocal choroidal metastasis from primary adenocarcinoma of lung, which was stage 4 with left eye pseudouveitis and neovascular glaucoma. And the patient was started on palliative chemotherapy with pemetrexed and carboplatin along with palliative radiotherapy for the brain mets. However, 4 months later, the patient succumbed to the disease. Uveitis mascarid syndrome are a group of ocular disorders that mimic chronic uveitis, and the malignant causes for this includes primary intraocular lymphomas, leukemia, uveal melanoma, retinoblastoma, metastatic tumors, and paraneoplastic syndromes that may mimic uveitis. In the eye, choroid is the most common site for metastasis owing to its rich vascularity, and the vast majority of ocular metastasis originate from the breast or lung, and nearly 44% of the lung cancers present as ocular metastasis. Histologically, adenocarcinoma of the lung has shown high frequent choroidal metastasis followed by small cell carcinoma, squamous cell carcinoma, large cell carcinoma, and carcinoid tumor. All the previous studies have shown that choroidal metastasis from the lung cancer are most commonly unilateral and unifocal, as seen in 82% and 77% of the cases respectively. However, in our case, the involvement was bilateral and multifocal. Pseudouveitis has also been reported in cases of disseminated lung cancer, where vitritis can be due to seeding of vitreous by malignant cells or due to a paraneoplastic process. The paraneoplastic vitritis happens due to the production of antibodies against the tumor cells that cross-react with the host antigens. Glaucoma secondary to intraocular tumors has been reported in 5% of cases, and neovascularization of angle as a cause of glaucoma in uveal metastasis, that too due to lung cancer, has been very rarely reported. In this case, the long-standing retinal detachment could have induced iris neovascularization and secondary glaucoma. I would like to conclude that malignancy can present with atypical or refractory uveitis, making it important for both the ophthalmologist as well as the physicians to consider this possibility, especially in cases where uveitis does not respond to the conventional treatment. And this case highlights the need to maintain a high index of suspicion for malignancy as a potential cause of uveitis, because early detection and treatment can significantly impact the patient's prognosis. These are my references, and thank you for the opportunity.
So how was the response after starting the chemotherapy? Did you see the regression of the tumor size?
The patient was started with chemotherapy, ma'am. After 1 month of starting the chemotherapy itself, the patient she passed away. Since it was a stage 4 lung cancer with multiple metastasis, there was no response to the treatment.
It's a typical masquerade. What was little atypical was that B scan showed a pretty solid tumor, but at least on the B scan we couldn't see a retinal detachment. Usually if there is a secondary and mets, the retinal detachment is usually very big. Compared to this, it's a very small size of mass and a very large retinal detachment. In your B scan, the mass looked pretty large, but we couldn't, at least on the B scan, see a good retinal detachment, one thing.
Maybe due to the long-standing detachment.
Or maybe the probe position was different.
So what were the clinical features that made you think in terms of malignancy?
Or was it just because of the CT report that you got?
All the uveitic workup we did, ma'am, and everything came normal except HRCT.
No, the question is, did you work it up as a regular uveitis, or the moment you saw, you thought this could be a masquerade? That is her question.
And after seeing the like B scan and all those things, and when we again went back and we asked her like any loss of appetite or anorexia, all this, when we asked, the patient told us, I have all those
So the patient had systemic
6 months she had
features also?
Features also, ma'am.
Okay. So it's important to maintain a high suspicion, keep it suspicious, and you should actually work up in terms of that. In fact, nowadays people are coming at a very young age also with such kind of a picture. So it's not only the older patients that you need to work up for malignancies.
Should write up this case.
Yes.
Sure.
Thank you.
Thank you.
Next we have Dr. Soni Sinha presenting retrospective observational series on clinico-demographic profile of retinochoroidal colobomas.
Good evening, all. So there are no financial interests in my presentation. So osteocoloboma occurs due to defective closure of the embryonic fissure in 0.5 to 2.4% per 10,000 live births. It occurs in isolation or with systemic abnormalities, and the phenotype is varied. The causes of visual impairment include refractive error, amblyopia, cataract, involvement of the optic disc fovea, and complications like lens dislocation and RD. So the present report encompasses the clinical characteristics of eyes with osteocoloboma. This was a paucity of recent data, especially from East Indian eyes, and so by doing so, we aim to contribute valuable insights into the morphological features. So this was a retrospective records-based observational series of 82 case records of patients presenting with osteocoloboma in the year 2024 in the retina clinic in the tertiary university-level teaching institute of Bihar. So the clinical characteristics and systemic associations were tabulated and are being presented. The 82 patients had a mean age of 19, and they ranged from 3 weeks to 75 years. There was a predominance of children less than 18-year-olds in 60%, with commonest in 11 to 20-year-olds. The patients presented most commonly with the diminution of vision in about 70%, and about 1/5 of them were actually blind. There was a preponderance of males, about 60%, and it was a bilateral condition in about 63% of cases. One case had a contralateral anophthalmos, and the other one contralateral nanophthalmos with uncertain chorioretinal morphology. If we talk about the visual acuity in colobomatous eyes, which were 136 out of the total cases, we find that a moderate visual impairment was present in about 25% of the bilateral conditions and 14% of unilateral conditions, a severe visual impairment in 12% bilateral, and blindness after examination. Blindness was found actually in about 40% of bilateral conditions and 60% of unilateral cases. So if we classify this according to the Eiderman classification, we find that the commonest presentation was that of type 1 in 41% cases, type 3 in 17%, and type 5 in 12% cases. These are some of the represented photographs of our cases. So the associated ocular abnormalities were iris coloboma, microcornea, nanophthalmos, nystagmus, cataract and retinal detachment, strabismus, uveitis sequelae, lens coloboma, myelinated nerve fibers, disc edema, and unilateral anophthalmos in one case. So there was so many systemic associations. If we talk about the history, there was a history of HIE and developmental delay, prematurity, maternal drug abuse, antituberculous treatment, and gastrointestinal surgery. While syndromes associated were golden house syndrome, CHARGE syndrome, a syndrome with club hand and hypoplastic left thumb, which we could not generalize, actually pinpoint association with microcephaly, with hearing loss, and with phrenoderma. So coming to the discussion, whatever studies that have been done in India regarding this have mainly pertained to the proportion of osteocoloboma which are prevalent in either blind schools or amongst patients attending visual disability clinics or for visual handicap certification. Or there has been a study about prevalence of coloboma in eyes undergoing cataract surgery. But if we compare this present study to the largest studies that have been done in our country, both from L.V. Prasad Eye Institute, we find that that our study was comparable in terms of the commonest age group with the study of Das et al. And in terms of male preponderance, which was slightly more in our studies compared to the earlier studies. The bilaterality of the coloboma was also comparable with another study, which was done amongst the pediatric patients, while blindness was again comparable with the larger study. So, avoidable blindness, like reasons for avoidable blindness, like cataract, were preponderant in our study, while as iris coloboma and microcornea or microphthalmos were comparable to the earlier studies, as shown in yellow highlight. The retinal detachment was, of course, very, very predominant in our studies, probably due to late presentation of our cases. The most common coloboma type was a type 1 in our case, while it was type 2 and type 4 in the earlier studies. So to conclude, more than 1/3 of the eyes are affected by blindness and about 1/4 present with retinal detachment. A high proportion of patients, especially children with visual impairment, cataracts, and retinal detachment is a cause of concern. Essential screening at birth and school entry must include fundoscopy to diagnose and treat causes of avoidable blindness associated with RC colobomas, along with visual rehabilitation. Thank you for your patient here.
Thank you.
24% of your patients had retinal detachment. What are the difficulties you have faced while doing the retinal detachment surgery for these patients?
Extremely difficult, sir, ma'am, because most of them were children. So actually, we are not doing retinal detachment surgery at present for very small children. So around 3/4 of them had to be referred to a center which was doing it.
And did you do a prophylactic barrage to any
Yes, we
patients?
did. We did.
What criteria did you follow to say that this person needs a prophylactic barrage around the coloboma?
Okay, so if we felt that the other eye had retinal detachment, definitely if it was a bilateral case, we went in for a barrage. Then again, if we felt that, okay, this was an intercalary, the thinning was there and maybe this will go into a break and then go into retinal detachment, we did do a barrage. A few barrages had to be done because there was a regmatogenous, possibility of regmatogenous retinal detachment because of a peripheral atrophic hole, peripheral hole present.
That's a different thing. I'm asking around the coloboma, just pertaining to around the coloboma.
Most of these cases.
You can follow them up with OCT on the coloboma.
Yes, definitely.
To look at the ICM.
Yes, yes.
Once the ICM detaches, that time you can
Definitely.
go in and do the barrage.
Yes, we are following up those patients. Thank you.
Do we have
Dr. Samender?
Dr. Raja Matangi. So Dr. Raja Matangi will be presenting atypical presentations of weak-edge disease as solitary choroidal mass.
A warm good evening to everyone here. I'm going to present a case of partially treated warped Koinagi-Harada disease masquerading as a solitary choroidal mass, which was a diagnostic challenge. Introduction, as we all know, warped Koinagi-Harada disease is a bilateral granulomatous panuveitic syndrome affecting the ocular, neurological, and cutaneous systems. It is caused by autoimmunity to the pigmented structures. Corticosteroids and immunosuppressants form the cornerstone in the management of weak age. Prompt diagnosis and treatment serves crucial to preclude visually disabling complications. The diffuse choroidal inflammation manifests in the OCT as subretinal membranes, high retinal detachments, and subretinal hyperreflective dots. Usually, the giant granulomas are being diagnosed as tuberculosis or sarcoidosis. However, atypical weak-age disease can also present as a solitary large choroidal mass with exudative retinal detachment, posing a diagnostic challenge to the clinician. Here, a 23-year-old female presented to the outpatient services with progressive painless diminution of vision in the right eye for 3 days, associated with right-sided tinnitus and a refractory headache. There was similar complaints a month prior, for which she was treated with systemic corticosteroids elsewhere, defaulting which she developed the current episode. On examination, the base-corrected visual acuity in the right eye was 20/400, and in the left eye it was 20/20. Anterior segment examination of the right eye showed 2+ cells, 1+ flare and pigments over the anterior lens capsule with retrolental cells. The pupil was circular and reacting to light. There was no RAPD. The posterior segment evaluation revealed creamy white subretinal lesion over the posterior pole with ill-defined margins suggestive of a choroiditis. There was dome-shaped elevation with over the macula, suggestive of exudative retinal detachment. The OCT showed submacular choroidal thickening and elevation. In the left eye, there was slight blurring of the nasal disc margin. However, the rest of the retina was within normal limit. The OCT showed increased subfoveal choroidal thickness, which was measuring up to 307 micrometers. A non-reactive MANTO, unremarkable CECT thorax, and an absent antecedent history of ocular trauma ruled out tuberculosis, sarcoidosis, and sympathetic ophthalmia as the leading differentials. The fluorescein angiography of the right eye showed diffuse leakage with pooling of dye over the macular lesion with a hot disc and peripheral vascular leakages. In the left eye, multiple pinpoint hyperfluorescent dots were seen in the peripapillary area. Indocyanine green angiography showed blocked senescence in the areas of exudative detachment and hyposenescent dark dots in the peripapillary area of both eyes, which turned to iso and hypersenescence in the later phases, suggestive of partial thickness granulomas. The patient was provisionally diagnosed as a case of incomplete walked Koinagi-Harada disease, who underwent partial treatment already. And the patient was again inducted on IV methylprednisolone. After 2 doses of IVMP, the visual acuity improved to 20/200. And after 5 doses of IVMP, there was significant reduction in the size of the choroidal lesion. She was switched to oral steroid with immunosuppression, and after 1 week of oral steroid with azathioprine orally, the visual acuity improved to 20/125 with significant reduction in the size of the choroidal lesion. And after 2 weeks of oral steroid with azathioprine, the visual acuity finally became 20/80 with complete reduction in the size of the choroidal lesion and restoration of the foveal contour. Repeat fluorescein angiography at 4 weeks of treatment showed a decrease in the level of hyperfluorescence of the lesion and decrease in the appearance of the disc. Thus, we want to conclude that solitary choroidal granuloma with overlying neurosensory detachment as a presenting feature of VKH is rare. It might have stemmed from abrupt cessation of elsewhere started corticosteroid. And what we want to convey is that morphological characters are liable to change with partial treatment and chronicity. Thank you.
Yes, nice case. You showed a follow-up FFA after 4 weeks with complete resolution. VKH is a stomal choroiditis. For you, the ICG might give you more insight information about the choroidal granulomas, and 4 weeks the FFA may look normal, but your ICG will pick up multiple choroidal granulomas still. So it will be in the subclinical stage, and immunosuppression definitely plays a role.
Yes. Thank you.
Thank you.
Do we have the last speaker, Dr. Chikitan Singh? So I guess that concludes the session. Thank you to all the speakers for the wonderful presentation.
Any other speakers have come? 3 speakers.
Is anybody else who wasn't there before come now?
Dr. Shivi
Nobody?
Jain, Adarsh Diora, Abhinyasu.
Abhinyasu.
Quite a few people did not.
They're asking for a photograph. We can put it. Please. So we don't know if you would have joined us. No, it's because most of the meetings are over. Sorry,